Hi, my name's Mark Nagel, and along with my co-authors, Dr. Jason Suggett and Dr. Jolien Mitchell, I'd like to share with you our study involving how tongue position can influence the inhaled particles from a pMDI along with a valved holding chamber. Getting benefit from inhaled medication is derived from either the total amount of drug deposited into the lungs or the quantity deposited in a specific lung region. Inhaled medication deposited in the oropharynx is generally considered to be wasted because it does not usually contribute significantly to the therapeutic response, although it may be partially responsible for some side effects. Inertial impaction in the upper airway accounts for a lot of the emitted dose from a pMDI. Oropharyngeal filtering, as it's sometimes referred to, can have a considerable effect on the aerosol that's eventually able to reach the lungs. The magnitude of this process will have effects on both lung deposition as well as its variability, with inhalers that deliver the lowest percentage of the dose to the lung having the highest variability in lung dose. Since the upper part of the tongue projects into the oral cavity, it can perturb the airflow that passes through the oropharynx, resulting in increased inertial deposition of larger particles or ballistic particles that cannot follow the flow streamlines. This process is of particular interest when a VHC is used, or spacer, with a pMDI, since the velocity of the emitted aerosol particles entering the oropharynx is significantly reduced by the presence of the add-on device. We hypothesize that by removing the tongue from our model, an upper airway adult oropharyngeal model, the mass of active pharmaceutical ingredient from the MDI alone or the MDI with VHC combination would change significantly. So the purpose of our study was to test that hypothesis, as it could have an impact to understanding both real-world clinical implications as well as future model development. Using the MRI scan of an adult male, two oropharyngeal models were created. The upper image has the tongue present, as shown in green, and as you can see, acts as an impaction zone if an MDI were to be inserted into the oral cavity. The second model had the tongue removed, allowing for a much larger opening or oropharyngeal cavity. To evaluate our two models, we used the fast screening abbreviated Anderson impactor, shown on the right, to test the emitted mass exiting the oropharynx. In this case, the standard USP induction inlet that you see in the photo was replaced with the model airway. Interior surfaces of both the oropharyngeal airway along with the impactor plates were coated with bridge 35 to avoid bounce and reentrainment. As a test aerosol, we used an MDI with fluticasone and actuated into the spacer on test with a 2-second delay to simulate what normally happens when a patient delays inhaling following inhaler actuation. The MDI was assessed similarly without the VHC, but in this case modeling perfect coordination with no delay present. In all instances, 5 actuations from the MDI were delivered at 30-second intervals and 5 replicate measurements made with the models with and without the tongue present. And lastly, fluticasone was recovered from the MDI actuator, VHC interior, model airway, and all the various components and analyzed with HPLC. The table below contains the results of our study, and I want to draw your attention to the mass that was deposited in the oropharyngeal airway with the MDI alone, whereas a nominal 125 microgram flow-vent MDI, 81.6 was left in the oropharyngeal airway, that's sitting on top of the impactor stack. When the tongue was removed, that was reduced to 64 micrograms. And then when the spacer or VHC is added, that mass has basically been transferred to the spacer, and we recovered 49.8 and 41.3, whether the tongue was present or absent. Consequently, though, the mass that we found in the oropharyngeal airway when the spacer was used was reduced to only 3.4 or 1.2 micrograms. So obviously having the tongue removed from the model represents an extreme condition and is really only intended to evaluate how sensitive the transport of aerosolized medication is into that enlarged oropharyngeal space. In reality, we want to highlight the fact that lowering the tongue can have an effect, and in a clinical setting may represent the opportunity to have more efficient transport to the lungs. So in the model where the tongue was present, obviously a more realistic scenario, the mass that was deposited in the oropharynx increased by about 28%, going from 64 micrograms to 81.6, while at the same time, the mass that we recovered from stage 5, that's in particles that have a better chance of reaching the lungs, was reduced by about 67%, going from 35.5 to 11.7 micrograms per actuation. So both of these findings indicate that a patient could expect to obtain a significantly smaller amount of deposition into the lungs if the tongue were in place. And our findings are consistent with those of Delvati et al., who used a model as well and found that tongue deposition increased from inhalers of the mouthpiece orientation with respect to the mouth, directed the aerosol directly onto the tongue. So when the spacer was present, the mass of fluticasone deposited in the oropharynx was smaller and increased only from 1.2 to 3.4 micrograms, while at the same time the mass recovered from stage 5, again, hopefully that represents lung delivery, decreased from 36.5 to 29.6 micrograms. Overall, the impact of tongue position in the model is mitigated by the presence of the spacer when it's interposed between the inhaler and the oropharynx. Retaining this ballistic fraction from the MDI is kind of the intended function of the VHC or spacer. So this process avoids a significant portion of the emitted mass from the inhaler reaching the airway, rendering the role of the tongue as a site of deposition less important. So obviously there's some limitations to our work here. It's obviously a very small sample size, an N of 1. We've assumed steady flow conditions rather than an inhalation maneuver, and also the fact that this nylon model is made of rigid construction, whereas the human oropharyngeal airway is going to be dynamic and going to stretch and enlarge depending on how things are taking place during the inhalation maneuver. Also, the fact that we've gone to two extremes, one with the tongue in its natural position and then where we've removed it entirely, which is very unnatural. So future studies should look to vary tongue position to better assess how sensitive this is to deposition. So from this, we're hoping that caregivers and healthcare professionals will consider tongue position as a key part of their inhaler use instruction, advising patients to lower the tongue to ensure a more reproducible dose. Furthermore, the value of the VHC has been demonstrated to mitigate oropharyngeal deposition, which should have been implemented in the first place if not already part of the drug delivery system. As more consistent lung delivery of inhaled medications is desirable and should lead to better disease control as well as a reduction in overall treatment costs. Thank you for your time.